All right, future docs, if you're cramming for exams and need to nail acute rheumatic fever, you've come to the right place. We're going to break down everything you have to know, from what causes it to how we fix it. Let's dive right in.
So here's our game plan. We're going to walk through this step by step, just like you would for a top-scoring exam answer. We'll start with the basics and then get into the really clinical stuff.
Okay, first things first. What exactly is acute rheumatic fever and what kicks it all off?
So here's the absolute key point you need to remember. AR isn't the strep throat infection itself. Nope. It's the body's own immune system going haywire in response to it, usually about 3 weeks after the sore throat is gone. It's a massive multi-system inflammatory freakout.
So think of it like a recipe for disaster, right? You've got a specific bug, group A strep, you've got a specific age group, kids, usually between 5 and 14, and it all starts with a simple sore throat. Yeah, you can even sprinkle in some genetic risk factors, like having HLA-DR7 or DR4, which makes some people more likely to get it. So you've got all these ingredients. How does that lead to the actual disease?
All right, let's get into the nitty-gritty. This is the how, the pathogenesis. Understanding this part is absolutely crucial because it explains everything else.
Okay, so there are a couple of theories floating around, but for your exams, listen up. You need to focus on the autoimmune theory. It's the one that's most accepted, and honestly, it's a fantastic example of a concept you'll see again and again: molecular mimicry.
It's basically a tragic case of mistaken identity. Your body gears up to fight the group A strep infection, right? It makes these awesome antibodies that target something called the M protein on the bacteria. But here's the problem: that M protein looks a heck of a lot like proteins on our own heart valves, joints, and even skin. So our own antibodies get confused and start attacking our own tissues. It's classic friendly fire, and that's where all the damage comes from.
So what does this immune system civil war actually look like in a patient? Let's talk about the signs and symptoms you're going to see.
Okay, the big one you'll hear about is this migrating polyarthritis. It's super characteristic. The pain literally jumps from one big joint to another, maybe the knee one day, the ankle the next. But here's the critical part. While the joint pain comes and goes, the inflammation of the heart, the pericarditis, that can cause permanent damage. That's the one we're really worried about.
Look, if you remember just one thing from this clinical features section, make it this. The joint pain gets better, the rash will fade, but the heart can be scarred for life. And that long-term damage is what we call rheumatic heart disease, or RHD. It's the whole reason this disease is so serious.
Okay, so you've got this patient with all of these possible symptoms. How do you pull it all together and make a definitive diagnosis? Pay close attention here, because this is pretty much a guaranteed exam question.
The answer, and you have got to know this cold, is a classic set of rules called the Jones criteria.
And here's the best part. The mnemonic is built right into the name. To remember the major criteria, all you have to do is remember the name JONS. How great is that?
Let's break it down. J is for joints, that migrating polyarthritis we talked about. O, well, picture the O as a heart, for carditis. N is for nodules, those little painless lumps. E stands for erythema marginatum, that weird-looking rash. And S is for Sydenham's chorea, those jerky movements. Seriously, burn this mnemonic into your brain. It's pure gold.
Now, besides the big 5 Jones criteria, there are also a few minor ones. Things like fever, joint pain without the swelling, and lab markers that show inflammation. They're not as specific, but they help build the case, They're supporting evidence. So here's the magic formula for diagnosis. You need proof of a recent strep infection, plus either 2 major criteria, 2 from the Jones list, or 1 major and 2 minor criteria. That's it. That's how you lock in the diagnosis.
Okay, we know what it is, how it happens, and how to diagnose it, so let's wrap up with the really important stuff. How do we treat it? And even more importantly, how do we stop it from happening in the first place?
The treatment strategy has 2 main goals. Goal number 1, eradicate the bug. We have to get rid of any leftover strep bacteria, and for that, penicillin is our go-to. Goal number 2, calm down the inflammation. This is where we use things like aspirin to handle the fever and painful joints, and of course, lots of bed rest.
And prevention is a huge deal here. We think about it in 2 ways. Primary prevention is simple. You get strep throat, you treat it properly with penicillin. That stops ARF before it can even start. But if a patient has already had an attack of rheumatic fever, we move to secondary prevention. This is a long-term plan, often involving regular antibiotic shots to make absolutely sure they don't get another strep infection that could trigger a relapse and cause even more heart damage.
Okay, let's pull this all together. Here is your ultimate high-yield summary slide, perfect for that last-minute cram session.
Seriously, take a screenshot of this, write it on a flashcard, whatever you do, commit this to memory. This is the absolute core of what you need to crush any exam question on acute rheumatic fever. It's all right here.
And there you have it, your complete high-yield explainer on acute rheumatic fever. We've covered all the must-knows, but I'll leave you with a final thought. We know that a simple course of antibiotics can prevent a lifetime of devastating heart disease. So why is ARF still a major problem around the world? What does that tell us about bigger issues like access to healthcare and patient education? Something to think about as you continue your journey. Good luck with your studies.